Okay, so let's jump right in. Microcytic anemia is one of those classic clinical puzzles that you see all the time. But honestly, getting from that first low MCV result to a diagnosis you're truly confident in, well, that takes a really clear systematic approach. Today, we are going to build that exact diagnostic engine piece by piece.
And this feeling, it's super common, right? You get that initial lab value back, and suddenly the path forward just feels kind of murky. This quote from a junior doctor we'll call Dr. Nancy just nails the exact challenge we're about to tackle. We're going to turn that feeling of being stuck into a plan that's clear, confident, and efficient. So let's meet the team for this case. We've got Dr. Yogesh, he's our senior physician, and of course, Dr. Nancy. But the most important person here is our patient, a 30-year-old woman who comes in with fatigue and a history of heavy menstrual periods. I mean, this is a textbook setup, and it's the perfect way to learn a really, really crucial diagnostic principle. And here it is. This is Dr. Yogesh's core philosophy, and it's so important. We always have to start with the patient's story. The labs, they're there to support and confirm what we're already thinking based on the clinical picture, not to lead us on some wild goose chase. So the big takeaway here is anchor yourself in the patient's story first. All right, let's actually put that principle into practice. Section 2 is all about gathering those really high-yield clinical clues, and we do this with a focused history and physical exam before we get lost in the lab results.
Dr. Yogesh suggests starting with these 4 key questions. Is this something that's been going on forever? Maybe hinting at something genetic like thalassemia, or did it just pop up recently? Is there an obvious place the patient is losing blood, like in our case? What about their diet? And hey, does anyone else in the family have a history of anemia? Just asking these questions starts to narrow down the possibilities right away.
And this is where the physical exam gives you these incredible, direct clues. We're not just looking for someone who looks a little pale. We're hunting for specifics, things like glossitis, an inflamed tongue, or chelosis, those cracks at the corners of the mouth, and especially koilonychia, or spoon nails. I mean, those are classic, tangible signs that practically scream chronic iron deficiency. It's the story the body itself is telling you. Okay, now that we have our clinical story straight, now we can finally turn to the data. Section 3 is all about decoding that complete blood count, the CBC. This is really the cornerstone of the whole workup, and it's where we get our first objective clues.
So here are the raw numbers for our patient. You can see the hemoglobin confirms she has anemia. No surprise there. But the real secrets are hiding in those other numbers. We're going to zero in on the most important ones, the MCV and the reticulocyte count, to really figure out what's going on under the hood. And this right here, this is our first huge branch point. The MCV, or mean corpuscular volume, tells us the average size of the red blood cells. Our patient's is 67, which is way below the normal cutoff of 80. This single number definitively tells us we're dealing with a microcytic anemia. That one fact alone narrows our focus down dramatically.
Okay, next up, the reticulocyte count. Now, reticulocytes are basically baby red blood cells. A healthy bone marrow, when it sees anemia, should be freaking out and cranking these things out like crazy. But a low count, like 0.8%, that tells us the factory, the bone marrow, isn't responding like it should. This is an underproduction problem. So, let's put it all together. What do we actually know at this point? We know the patient has small, pale red blood cells. That's the microcytic and hypochromic part. And we know her bone marrow isn't making enough new ones to fix the problem. That is a clear, concise summary of the data so far. With that problem statement locked in, we can move to Section 4, building our short list of suspects. This is so important because having a systematic differential diagnosis keeps us from getting lost and makes sure we don't miss anything big. For microcytic anemia, this is the classic list you've got to know. Now, based on our patient's history of heavy periods, iron deficiency anemia immediately rockets to the top of our list. But a good clinician always keeps the others in mind. So how can we quickly tell the difference between the top 2 contenders? Well, here's a fantastic little clinical pearl, the Menser index. It's just a simple calculation using 2 numbers we already have from the CBC. And it's a nifty little trick that uses the underlying biology to give us a powerful clue. The key is understanding why this actually works. In iron deficiency, think of the bone marrow factory as running out of raw materials, so it produces fewer cells, and the cells it does make are smaller. Both the MCV and the total red blood cell count drop, giving you an index over 13. But in thalassemia, it's a totally different problem. It's a genetic defect. The factory is running at full blast, but it's making defective, small products. So the MCV is low, but the RBC count is actually high. That gives you an index less than 13. By the way, for our patient, the index was 18.1, pointing very strongly toward iron deficiency. So our suspicion for iron deficiency is super high at this point, but we need proof. And that brings us to Section 5. The next step is not a shotgun approach where we order a million tests. It's about ordering specific, targeted tests to confirm our number one suspect.
One of those key tests is transferrin saturation. And here's a great way to think about this. Imagine the iron transport protein transferrin is a bus. In iron deficiency, the body makes more and more buses, trying desperately to find any iron it can. But there are very few iron passengers to pick up, so the bus is mostly empty, which means the saturation is very, very low. And here it is, our first aha moment. The patient's serum ferritin is 5. Now, ferritin is the most direct measure we have of the body's total iron stores. A value this low is definitive. There's no question about it. The iron tanks are completely empty. And the second piece of evidence just seals the deal. Her transferrin saturation is only 8%. Just like in our analogy, the buses are, in fact, nearly empty. There is just not enough iron being transported to the bone marrow factory to make healthy red blood cells.
So, with a ferritin of 5 and a transferrin saturation of 8%, there is absolutely no doubt we've successfully gone from a broad clinical problem all the way to a specific confirmed diagnosis. The medical mystery is solved. It's iron deficiency anemia.
This quote from Dr. Yogesh just perfectly sums up the why behind it all. The problem isn't the factory itself. The assembly line is working just fine. The real issue is a supply chain failure. Without that key raw material iron, the factory can only produce small, underfilled products, which are those microcytic, hypochromic red blood cells we saw on the CBC. So let's boil this whole thing down into our diagnostic engine, our key takeaways. Number 1, always start with the patient's story. 2, use the MCV to classify the anemia and focus your workup. 3, for microcytic anemia, especially with a history of blood loss, your prime suspect is almost always iron deficiency. And 4, confirm that diagnosis with specific tests like ferritin. It's a framework that's both reliable and incredibly efficient. And, that's the real point of all this. This isn't just about one case of anemia. It's about a way of thinking. So the final question is for you to think about. How can you take this patient first, classify second, confirm third model, and apply it to the next complex clinical puzzle you come across?